And I invite Dr. Prasanna Venkatesh to speak on this interesting topic.
Thank you. Nice talk, Unni Krishnan sir, and thank you, Dr. Shroff sir, for giving this opportunity. Heidelberg team. First, I would like to thank the Heidelberg team. This talk is a long time due. On November 23rd, I did want to do this talk, but unfortunately, due to unforeseen events, I was not able to do it. I think the whole Heidelberg team know why, but it's like a complete circle for me because I take immense honor and pleasure. What I missed 3 months back, I think I'm here today and looking forward to this. So Anterion, as you all know, Anterion is something that is being marketed for refractive surgeries or for lens or cornea. So this is a totally unexpected thing that I am exploring into glaucoma. So sit back and relax in the next few minutes. I'm going to show you how Anterion has been customized for my glaucoma practice and how I'm going about it. So I would like to thank my mentor as well as Martin Long and Shanaz and the whole Heidelberg team for introducing me. Mr. Venkatesh is there from Trosh Bro. So I'm a MIG surgeon, I'm a glaucoma surgeon and I'm doing more MIGs. So what happened with Anterion is I started imaging the different kind of MIG surgery that I'm doing. So bent ab interno needle goniectomy. So what is this procedure is, we just bend the needle opposite to capsular axis and we open up the trabecular meshwork. So you can see that with a 26 gauge needle. So what I do is we just open up the trabecular meshwork. So a lot of mixed surgeries are now being the talk of glaucoma town. So how do we evaluate a mixed surgery? Because there is no particular marker and a ASOCT or a UBM is not high resolutive enough to really go about it. But with Anterion, and I'll show you another surgery called KDB. So 26 gauge needle is done for bang. It's called bent ab interno needle goniectomy. And then there you can see a direct gonioscopy here followed by the KDB. So in this we can see the blade is made for this. So it's a dual blade called the Kahook dual blade. So this is upcoming in the glaucoma sector assay. I just wanted to show the procedure for the neophyte so that what we are going to talk on, it's going to make a lot of sense. So this is made for that, and there is another one called the 26 gauge needle, and this is an animation of the same which is done for specialized for this kind of a procedure which is more refined. It ramps up the trabecular meshwork. So what I have seen in Anterion is, so this is post KDB and this is post bang. I wanted to evaluate the angle structures because in KDB what I started observing in the gonioscopic findings are the leaflets, the trabecular meshwork leaflets were very minimal compared to the bang. So you can see that in this Anterion picture, we are now publishing this in the next issue in IJO. Yeah, if there is a pointer, it will be very nice. Can I have the pointer, AV team? Yeah. So you can see this W sign on the red arrow here. So this is a complete excision of the trabecular meshwork, and yeah. Thank you, sir. So this doesn't happen with the bang. So this KDB gives you a complete Y sign which we are publishing in the next issue. Whereas with bang you can see the 26 gauge needle is not made for it. So what happens when you use a needle and open up the trabecular meshwork? There are some leaflets here and there like a curtain remnants. So that gives you a remnant. So this is one imaging device is actually imaging the trabecular meshwork. This by trial and error we have got it done and we are now publishing this. You can see this remnant here. This serves as a precursor for a peripheral anterior synechiae or even trabecular meshwork to actually again close back. So let us see other mixed surgeries like G1, right? iStent and iStent inject. So these are something that are being spoken highly about in the market. I need the cursor also. I'll be forwarding my video. Yeah, I'll not be able to forward the video. Cursor is fine. So this is a G1, iStent G1, where you can see that the tangentially the stent is placed. The stent location, because if it is not working, why it is working. Trabeculectomy, we do know how it functions the way it functions. But mix is something which is very much new and we have to really know how things are. So we do have some visual markers like the vessel getting perfused in the episcleral vessels that you can see here, which is getting perfused as I place the stent. But iStent, you can see that this is a 1 year follow-up patient. It helps you not only along with gonioscopy, there is a back shadowing, especially in that particular plane where in the exact pigmented trabecular meshwork that you do. Again for G2, generation 2 series, not one but we place 2 stents, right? So it's an axial injection where you place 2 stents on 2 clock hours apart. Of course, you get a visual marker of a paralimbal blanching. A white area appears as you place the stents in the right plane. Again, you can see beautiful 2 stents. Anterion evaluates it, whether it's in the exact plane of choice that you want to. If the IOP is still high, we can always go back. Then comes suture gat. Suture gat is one technique which happens with a 5-0 Prolin suture. It is a very cost-effective mix and which is being highly recommended by all the mix surgeons for drop in intraocular pressure. What you do is you just make a nick. in the MVR blade, in the posterior or the pigmented trabecular meshwork, and then what you do is you pass a 50 prolin suture, make the mushroom a tip into it, a 24-25 throws, and what happens is this comes out the other side, just like a donut, right? You keep on passing and it comes through the other side. You can see that now the suture has come 360 degree the other side. So we don't really have any particular modalities to evaluate the Schlem's canal, the trabecular meshwork, because mix is the happening, hot and happening in glaucoma. So what Anterion gives you, it gives you a bird beak configuration. You can see 360 degree the Anterion imaging was done, and there is a bird beak configuration. So with the bird beak configuration, what happens is, it's like tearing a paper. If you tear a paper with a thread, always the paper can again go back and join with each other. But with KDB, you saw the Y sign, completely the trabecular meshwork was scooped away. So this was our observation and publishing soon in IJO. So I wanted to start with mix because this is something which is very, very important, and I think Anterion helped me a lot. No financial disclosure here, I do have the machine, but this is something I feel any anterior segment surgeons who is doing mix, you should evaluate it and see how your angles are, because your ASOCT and UBM will not give you this resolution. What Anterion is giving, I feel you can even go one step further and evaluate the Schlem's canal as well, which we are actually doing. Of course, lens has a role. Whenever you remove the lens, the chamber deepens. So as a glaucomatologist, always that is more important to me. This pinch region or the iris lens channel, right? This is the region that pupillary block happens. So I need a lot to work in this region, study what happens in this region. Now I'm shifting from this area to this area. So this pinch region evaluation, how it really happens, the iris lens channel, because ultimately we do YAG-PA because we don't want the pupillary block to happen. So we make an opening for this particular patient. So Anterion before and after, we started imaging patients how YAG-PA eyes are. So I'll just show you, I'll skip the procedure, we all know the procedure. So before and after LPA, you can see immediately taken there are a lot of pigment dispersion, but you can see the opening here, and you can definitely see the angles that are opening up. You can see how in the age here before and after, again another patient, see you can see the angles here. I have made a PI here, you can see how much the angles are actually opening up. You can see how narrowed the angle recess is here, but this angle recess, despite the lens being, you can see how it has opened up. So Anterion is giving more light to these structures as well. Of course, if you are doing a cataract extraction, definitely the iris will fall back, definitely the ciliary body will also fall back. These are our own animations. Definitely the scleral spur is also falling back. We are able to see this in Anterion as well. The breakage of a peripheral anterior synechiae for that matter. Again, this is a very important real-time scenario which I wanted to share. This is one of my cases of combined surgery. I started the surgery, things were all going as per plan, but then the surgery got complicated. You can see that there was an iris prolapse, corneal edema, one of my earlier cases, where there was a PC rent, which I managed very effectively. You can see that the rent has happened, but then the cornea also was very cloudy, but that's not the point here. The surgery was managed, the antivitrectomy was done, and all's well ends well. It was a clean case, and finally the lens was placed in the bag. You can see this is me placing the lens in the bag. The PC rent was very small, and then it all's well ends well. I was able to complete the surgery, but Anterion gave me an idea that how can I go back and evaluate this patient for long-term lens stability, right? So this you can see that this is an eccentric PC rent. So I went back to my drawing board in this patient once the surgery was done. Of course, at the end there was some completion that I had to do for the trabeculectomy. Now the patient is 24-month review. So this is an undilated one, and then you can see this is a bleb, all is fine, the patient is happy, 10 millimeters of mercury. So what you can see here, the PC rent that happened, I am still able to monitor it at a quantifiable level. So the lens stability, it was a monofocal, but if I had chosen a toric lens for this particular patient, you can see that the PC is also very much where the PC is decent. When I dilate the patient now, even that can be evaluated. I think these are things which are very promising. You can see the slit lamp image of the same particular patient. And then not only that, we have done many publications with the spectralis anterior segment imaging module and Anterion for that matter, which I would like to share. This is an accentual Rieger syndrome who had an incidental coloboma. You can see that even the posterior embryo toxon can be done the attachment that happens, right? Because when you see pediatric babies tomorrow, angle dysgenesis is a very important topic that we need to really get a hang of. Actually, the angles are okay, but the posterior embryo toxon is preventing you from doing a gonioscopy, and in gonioscopy you won't be able to see it, but with Anterion you can bypass it and you can actually see these things. And again, this is a completion of the same where there's a patient and an incidental coloboma along with it. And this is one of my cases I presented in Rome, Italy last year in the World Glaucoma Congress. So this particular patient presented to us after he was done ICL elsewhere, and he was not happy because he developed epithelial edema and he was advised ICL explantation, and obviously he's not very happy. So when he came to us, a simple examination of ICL mapping, like you can go ahead, get your imaging done, see whether the ICL vaulting is perfect or not. You can see that the ICL vaulting was perfect. There was no issues with the ICL, so we went ahead and did a trabeculectomy because the gonioscopy was more pigmented, and the re-diagnosis which was done as angle closure elsewhere, we diagnosed it as open angle, and the treatment was a simple trabeculectomy with Ologen, and the patient is now on 5-year follow-up and is very happy. We did have the anterior segment imaging module back, not the Anterion at that time, and you can see the follow-up pictures, the patent ostium and the healthy functional bleb, and the patient is very happy. Again, another case which really helped me with Anterion was this particular patient. We were using a lot of bleb Ologens. Patient presented to us 3rd month, 6th month or after a year with a discolored Ologen bleb. So as a glaucomatologist, we were very confused, like what are we seeing? Whether is the sclera thinning or is something happening in this particular area? We were able to identify that the Ologen implants of one particular batch had a side effect that after a combined surgery with the intracameral antibiotic that we were using, it became discolored, where you can see that this is a discolored Ologen bleb that we were able to image with an Anterion. So we went ahead and published that as well. And this is one which I was lucky to be part of, the Uncharted Eye, which we launched at Mumbai in August 29th, I believe. The nuclear sclerotic cataract, or even the posterior capsule, you can see the edge. This was one of my images where it really helps you in pre-planning. Hydrodissection or hydrodelineation, many a time we end up doing it wrong and we end up with a complication. And this is again one of my publications of a Urates Zavalia syndrome, because after an eye stent placement, again these are images from that where you can see that we have imaged it, and Anterion really helped us to understand how it happened the way it happened. The implant was slightly not the place where we wanted to, and also there was other findings like a a pigment dispersion. It was more a pigmented angle, as well as there were many studies where an IOP spike can actually cause a Urates Zavalia syndrome. But this gives you a complete holistic evaluation of one particular gray area, which is of high resolution, which is what I would like to put it. And then you can see we are doing extensive anterior segment artificial intelligence studies with Anterion. I would like to show the schematic plan of our original study, which is due for publication. This is the image that we started with ultrasound, because ultrasound biometry as a glaucomatologist, that is what we always start with ultrasound, UBM. So we started mapping the trabecular meshwork and the scleral spur. Then we innovated a protractor here, as you can see. This is a novel protractor that we made where the image can automatically detect whether it's open angle or not, along with the angle. You can see this is an AI protractor that we are trying to make. With UBM is what we started. Then we went to Anterion, and you can see that we are working extensively with, the company people can correct me if I am wrong. As of now, I don't see a protractor which gives extensive anterior segment grading. So we are working on that, and along with that, we are planning to extensively evolve into other parameters which are very important for glaucoma as well. Again, this is the same template that I showed in the UBM. We are training the machines on how to pick up the trabecular meshwork, how to pick up the scleral spur, because for mix going forward, these are very important areas we need to understand so that we can get the Schlems canal imaged and go forward. And yeah, spectralis anterior segment module is another one which is also useful, which we are working there as well, along with Scheme plug imaging. We annotate the machine, and then with this algorithm, the machine will be able to detect all these indices, whether it's angle closure or open angle, scleral spur, angle recess and whatnot. Unlocking potentials. So these are some of the very eccentric images that I started collecting. I don't know why I started collecting, but I just thought I'll share it quickly as a part of the ending. See, microcystic corneal edema. So these are some things which I have never seen any machine give me these things. Anterior capsular phimosis, can see in an extensive level, anterior dislocation of lens in anterior chamber. This is an award-winning image in ASCRS this year in Boston. I just got the image the news 2 days back. So I think these are some things which is very fascinating. Adherent leukoma with anterior synechiae. I still don't know what is the clinical implication, but these all look very eye candy. An aphakic patient with silicone oil, a bleb, one of my patients, again with endocyridectomy, BCL in situ. You can see the fine BCL in situ. You can see the posterior synechiae in a uveitic patient, posterior synechiae in a patient with IOL, ICL vaulting, which I already covered, whether it's a good ICL vaulting or a poor ICL vaulting. And we have extensively published all our images in our regional journal, be it evaluation of a nevus, be it a staphyloma that we are evaluating. I think we have to think beyond cataract, beyond cornea, and we also started innovating with our holograms. People who know that we are doing a lot of HoloLens innovations as well. We are trying to incorporate the Anterion images for anterior segment imaging. With the headsets that we have slowly but steadily started to make evolution into the anterior segment imaging, so that not only posterior segment that retina and OCT gives you, we need to go into anterior segments as well. And as a glaucomatologist, my area is more of that. But obviously, as Unni sir covered, definitely all modalities, all multimodal imaging can be worked with it. And this is again another data of mine. We had a phenytoin induced bilateral angular attack closure patient. Again, this is again, you can see the imaging, it gives you extensive before and after YAG-PA. See the amount of opening that you can really appreciate. This is seam plug imaging. In seam plug imaging, you can't appreciate it that great, but with Anterion, I think the image speaks for itself. We went ahead and published this as well. There are again many publications of mine which I'd like to share. You can see that this is one of the vitreous bulge that happens. Why Anterion again? See, I was very confused whether the vitreous was actually touching this patient or not. If she was a rural patient, an 80-year-old woman from a village, she was actually seeing well. Whether I need to really go in and operate, because the vitreous was in constant touch with the cornea, I need to make a decision whether I can just leave her or whether I can just go ahead and just do an anti-vitrectomy so that it doesn't touch. See the resolution that you get, right? If you zoom this picture even further, you can see that it's actually very close but actually not touching. So then finally we didn't do anything for her, keeping in age and the compliance and the other part of it. Again, you can see the bleb morphology, how much you can actually dissect the bleb and see, because clinical imaging is one, but see how the MMC bleb which fails, no, this is a ticking time bomb. We glaucomatologists call it a ticking time bomb. It's a white bleb. After 20-25 years after MMC, the bleb gets thinned out. You can see how AIOC2024 and seam plug imaging gives the ticking time bomb. So these are something which are not explored, and we are going the maximum. And Iris Bombay, this is again a patient who had a superior tunnel SACS. One of the residents performed it. The tunnel was not stable. You can see how this is a pseudo bleb. See how the loci of the bleb are. There are two loci and a septae. A septae of the conjunctiva goes and attaches it inside. There is so much to explore, my dear friends, with anterior segment imaging. I think we need to explore and dive into more. I just wanted to share some of, this is again one of my microspirophakic patients. You can see how the lens is coming and touching it. I'll just rush through the slides. Again, this is a cough syrup induced bilateral acute angle closure attack in a predisposed hypermetropic patients. You can see before and after YAG-PA what happened, and then the patient was treated well. And again, last scenario, in the lockdown, we were not able to get corneas. We were not able to get eyes. That time, what happened is we were doing patients who had to be taken for trabeculectomy. We were doing a novel technique of using E-polytetrapolyurethane. It's nothing but it's called Gore-Tex. So whenever the patients had a overfiltration, we were using Gore-Tex and then we were tapping it, because ours is a teaching institute. The teaching never stopped. So we were using Gore-Tex, and then we evaluated whether that tissue is actually enough to hold the conjunctiva. But when we studied and when we evaluated, you can see that there was thinning that was happening, and there was a fistula here, meaning that the surgeon, when there was an iatrogenic entry, we tried to use Gore-Tex to arrest the fistula, but it was not working. So because we were not able to get scleral patches, we were not able to get corneas. This is in the first lockdown that I am speaking. So we did have Gore-Tex, and we were able to at least see where we are or what we are. And you can see that this is again now the patient. Recently we are following up the patient very closely. The fistula, we did think of a fistulectomy, but we didn't do it because when the patient came priorly, this was a fistula. We didn't do a close monitoring, but see how the fistula has become now. With anterior segment imaging, we are seeing the fibrosis. The fistula was like this. Now it is undergoing a fibrosis, so I don't want to touch it. So these are some of the images that I wanted to share, because I wanted to throw a different perspective on anterior segment imaging. The machine is beyond retina, beyond the optic disc. I think anterior segment, blebs, conjunctiva, sclera, I think there are so much more to explore. This is just some of my observations which I ended up publishing in different journals. So thank you once again, Heidelberg team, for taking care of me when I had an emergency in November 23rd, and I'm up and running now, and I'm happy that the talk, which was long time due, it had to happen at AIOS Kolkata, and thank you once again for the opportunity.
Thank you. That was a brilliant gamut of beautiful images and innovation. I just have one question.
Yes,
you
sir.
spoke about MIGS and how Anterion has helped you with MIGS.
Yes, sir.
So have you ever had to do a redo surgery in MIGS and based your redo based on the imaging on Anterion?
So after I do a mixed procedure, clinically if the IOP is under control, I am very happy. I don't go and over-explore. Only if the IOP is not controlled, because I am taking a mild or a moderate case along with the phaco. I do a phaco and then a mix. When the IOP is not under control, then I need a non-contact modality because immediate post-op gonioscopy is not going to be done. I do an Anterion. If Anterion is seeing that there is something, some kind of trabecular meshwork that is remnant, some kind of thing that is happening, that could be the cause, and at least I can start the patient on a medication. Then maybe, or if the patient is able to understand, then I can go for another surgery. For example, I have placed a G1 stent. I have not done an excision of trabecular meshwork. In 1 week, I am able to see that the patient is not going to improve with one single stent. Then I tell the patient, see, your eye, I did think that the stent was enough, but it seems that I need to open up the trabecular meshwork on the left and right of it as well. It's called combined mixer. We are coming out with papers on that also. So it's just like taking the patient for a toric IOL rotation, which happens, right? Maybe if it's not in the proper place, we take him up in a week or so. So I tell that, and maybe we take him and we can do an extensive additional mix surgery. Or if you think primarily the patient needs 2 procedures or combined mix surgery, you can do that way also. Yeah.
Thank you so much,
Yeah,
and
thank
wish
you,
you
sir.
all the best for the SFO session. I
Yeah,
think.
thank you, sir.